Dear Isabella Roqueta, here we are again. You're in the second step of our journey as my scientific co-host. Very exciting session. Welcome back. We'll address 3 questions tonight, and for each of these questions, you will be able to vote whether you believe it's true or false or you don't know. And the voting is done in exactly the same way as we just did in the battle. You can scan the QR code, which is on screen right now, or right below your video player right here. So, Isabella, to kick off, what is our first question and who is the expert addressing it?
Absolutely. Well, the first question, is it true or false, is the use of checklists decreases the number of complications, and the answer will be given by Christian Schmitt from Germany.
Is it true that the use of checklists can reduce the number of complications? Well, this is a very good question, and I'd like to answer that question in this short video based on scientific evidence and my personal experience. First of all, it is well known that human errors are common and widespread and that they occur in many different constellations. Most of these errors can be absorbed by the system, but a few of these errors lead to complications during the procedure or afterwards. Therefore, it is very important for us that we accept the circumstance that we fail and make mistakes, since clearly this is part of human nature. Since the entire elimination of human errors is not possible, we need to find ways and solutions to gain some degree of control over human actions and errors. Simple tools that can be implemented in a variety of processes with the goal to reduce the number of errors and complications are checklists. Checklists function pretty simple. They function as barriers for the avoidance of complications, and they can absorb errors that occur in daily practice. Such checklists are already used in medical disciplines with success. They demonstrably reduce the number of complications and especially the number of life-threatening complications as well as mortality rates. In dentistry, the use of checklists is not very common, and there's not much data in the literature about it. But dentistry is a very prone field to complications and errors. Looking at the literature, analyzing adverse events in dentistry shows us that the highest frequencies of adverse events occur in oral implantology, followed by endodontics and oral surgery. According to the results of that study that I'm referring to, 44.3% of that adverse events which took place were due to predictable and preventable errors and complications. Therefore, they have been avoidable. In a recent study of our working group, published in Journal of Oral and Maxillofacial Surgery, we analyzed the outcome of surgical safety checklists implemented in the ambulatory setup of the Department of Oral and Maxillofacial Surgery in 2017. The used checklist was especially adapted to the needs of the ambulatory setup for dental alveolar surgery and implantology. Outcomes clearly showed that with the use of the checklists, significantly lower incidence and complications occurred as compared to outcomes without the use of the checklists. This was also due to significant better team communication and the reduction of stress level with the use of the checklist. Now, answering the question of the session, is it true? I certainly have to answer with yes. Checklists can reduce the number of complications, and I'm also convinced and confident to say that checklists will also improve your treatment outcome. I hope you like my little video, have an exciting session in Congress, and I wish you all the best. Thank you.
Thank you, Christian, for showing us really based on research that this is in fact true. Now, Isabella, it seems to be an emerging theme in our sessions here tonight. Let's quickly look at the voting results. I think we have a lot of people who joined us right from the start from your Tell Me More About session with Frank Renoir. 90% of our audience that voted actually selected the true option. Only 10% to convince here, because this is in fact the correct answer. Isabella, a lot of science.
Well, it's interesting to see the 2% that say false, because we have listened to Frank Renoir, we have listened now to Christian, and I think it makes sense that a layer of safety, given whether it's X number of checklists, whether it's a communication, a sterile cockpit protocol, it cannot go wrong. I mean, we have all gone through those scenarios where patients are confused on which medications they assume or not, whether they are allergic or not, and then you actually give them a certain drug, and it happens to be all in confusion because the checklist was not followed, and so on.
Yeah. So let's see if we can try and make it practical, because a checklist is kind of a broad word. What specific checklist do you use yourself, for example?
Well, we are in fact quite lucky because Frank Renard has published quite a few pieces of information on dentally related checklists, and even Christine has just shown us a paper where we can actually use these checklists. So we must not reinvent the wheel.
Right, otherwise we'll listen to this like, okay, let's make a list and put it in the kitchen.
But let's remind ourselves that we are simply mimicking what our fellow colleagues in the medical field have been doing for forever. And I think this is something that has to be stressed. The answer to this question is yes, and it really does help to prevent certain errors. Then obviously each one of us will implement the appropriate measures in their own private practice.
Exactly. Now, this is the second time I hear tonight they do this in medicine, they do this in aviation, somehow they don't do this in dentistry. What's wrong with the dentists? Why don't the dentists do it?
Well, that I don't know. But certainly, as Frank was saying, I think he's right. I think this is a topic that is seldomly spoken about. And as I said before, we grew up at the university level or even the postgraduate level, this is not taught. So I believe that things have been changing over the last few years, and now this human error in a way topic has been more and more available with the literature. We just have to read and learn.
Well, we're super live. I just see a live question coming in from Noah Grace about the specificity of the checklist. The question reads, does everybody use the same checklist in the office, or does everybody kind of need their own checklist in their specific role?
No, clearly the checklists are according to various levels, and at the nurse level, when it comes to the stock, for example, of certain materials, then they will obviously follow their own checklist. And I refer to a case which we were discussing with Frank earlier on, where sometimes mistakes are made because the stock in the practice is lacking that specific material, whether it's an implant, whether it's a membrane, and you adapt to whatever you have, because it's embarrassing when the patient is sitting on that chair saying, I am sorry, we ordered a different implant, or we are lacking this certain diameter or length, and this is very dangerous. And this can be controlled. So there are various levels.
Yeah, and the beauty is it shows it's not only about the surgeon that we talked about with Frank, it's basically with everyone in the team working together for the perfect result.
It's actually mandatory that it is a team approach, completely. And this goes back to the communication between the members of the team and the professional.
Exactly. Do you think we got it now?
I think we got it now.
I think we got it. Let's move on to our second question. Again, you can vote if you're just joining. Scan the QR code, which is right below the live stream player. You will now see appear the new question that we see a video on. What is the question and who's presenting it, Isabella?
Now the question is, in the regeneration procedure, is it possible to leave a membrane exposed without any consequences? And the answer will be given by Paolo Casentini, a dear friend from Milan, Italy.
Hello to all colleagues and friends from the IAO. It is wrong and it is true in the same time. It is wrong if we consider a guided bone regeneration procedure applied to a healed site, because in this clinical scenario we usually recommend to achieve a primary intention closure of the flap, and so the graft and the membrane are fully covered by the flap. And if the membrane becomes exposed, we usually have infective complications and reduce bone formation, like we see in this first clinical case where a non-resorbable membrane was applied. Then, unfortunately, the membrane became exposed. You see in slide number 2 after a period of 2 months. And then we had to remove the membrane, partially regraft the site, and in any case it was possible to place an implant after 6 more months of healing, combination with a connective tissue graft, and the case was finalized in an acceptable way, like you can see in slide number 5. But it is also true, because in another clinical scenario, like the post-extractive soffit, where the anatomy of the defect is more favorable, is more protective, we can intentionally leave a membrane to heal exposed and to seal the socket. In this case, we will not have negative consequences. The membrane will usually resorb in 2 or 3 weeks if it is a collagen membrane, and the site will usually reepithelize in 4 weeks. And at the end, we will also have more keratinized tissue. So let's see a couple of cases. A molar site is grafted after extraction, and you see a collagen membrane is applied to protect and to seal the socket and stabilize with some sutures. The typical healing process is highlighted by slide number 7, where you see how the site reepithelizes in 4 weeks. And then after 6 months of healing, it is possible to place an implant in the best prosthetic position and finalize the case. You see the final result in slide number 9. A final case, a central incisor that needs to be extracted. You see it in slide number 10. And again, the decision was taken to go for a ridge preservation procedure, also in this case. And you see in slide number 11 how the membrane is left to heal partially exposed, but also in this case, no negative consequences, and a perfect healing of the soft tissues, also in combination with the good healing of the bone. So it is possible after 6 months to go back to this case and place a prosthetically driven implant and finalize the case, like you can see in slide number 14. To summarize, the answer really depends on the clinical scenario, and of course, this is not only my clinical experience, but it is also what the literature says. Ciao.
Thank you, Paolo, for showing how this can be both true and false depending on the clinical scenario. Well, Isabella, this is a bit tricky. Let's see how our audience has voted. I think they're all across the board. 41% votes true, 60% votes false, and only nobody doesn't know. So I guess we have no one to educate here, but for further, let's dive into how can this be both true and false, Isabella?
You see, the poll doesn't surprise me, because you have approximately, let's say, well, 50-50. You have 60-40 to be honest with you, but you see 40% say that it is false. 60% say that it is
so
not
you
true.
cannot leave the membrane exposed.
Now, the point is, I think Paolo explained it very well. First of all, it depends, yes, on the anatomical site and the indication. As always, we're always talking about the correct indication, but it also depends on which barrier membrane we are talking about. He showed correctly the cases with non-resorbable membranes and the cases with collagen resorbable membranes. We all know that the two do not match when it comes to potential complications or consequences if left exposed. Now, it is very now clear that when PTFE membranes or non-resorbable membranes are left exposed, they tend to cause an inflammatory reaction, an inflammation of the area. This was very true with the old generation membranes where the PTFE was expanded, for example. Nowadays we have more dense pores. But, however, they still represent, in a way, a threat if they are left exposed. Perhaps not so aggressive as a reaction when they are left exposed like the previous generation ones, but we are clear in saying that the GBR in healed ridges require a primary intention closure. So those flaps have to close over the membrane.
Exactly. So there's basically two things here we need to consider: the type of membrane
Yes.
and the type of closure after surgery.
Yes, well, the closure clearly it depends on the actual indication of the regeneration that we are doing. So as we said, whether it's horizontal, vertical, it doesn't matter, but it's from a healed ridge, then the soft tissues have to be closed. On the other hand, when we are using collagen barrier membranes, and he has shown 2 cases of what is defined as socket preservation or alveolar ridge preservation more correctly, then the question is, does it bring any consequences? The truth is that the consequences can be digested. So it's not fair to say, yes, you can leave it exposed and nothing happens. I think it's wiser to say, if they are left exposed, then we know they reabsorb in a very fast time frame, and the secondary intention healing is acceptable, especially in the non-aesthetic results, in the non-aesthetic sites.
Area, yeah. Any specific measures or things we need to take into account when that happens?
Well, clearly when we have complications from membrane exposures, yes, but it really much, Garrett, differs from the site, the indication, and most importantly, the membrane. Exactly. So if we do have an opening, a premature opening of the soft tissues over a non-resorbable membrane, there are now specific protocols that we should be following in order to avoid losing all the graft that we have positioned. And that's why, you know, these membranes are still nowadays a challenge to be used, but if the soft tissues are maneuvered correctly, the percentage of exposures is really minimal if there is obviously a learning curve in dealing with the soft tissues.
Exactly. So the next time I find 2 dentists battling over whether the membrane can be exposed or not, I should actually ask the question, what membrane are you guys talking about?
Yes, correct. I think that's a good valid point.
That's how we do it,
yes.
Right? So we move on to our third question of the night. Again, I'll launch the vote. If you're just joining, scan the QR code right below our live stream player, and you will then appear to you the next question. What are we voting on?
So now we are voting on whether we can grow a peri-implant papilla in a predictable way. And the answer will be given to us by Joseph Kahn from Loma Linda in the USA. Lucky him.
Hello, my friends from EAO. Today the question is, can we regenerate a papilla around implants predictably? The key word is actually predictability. There are 2 scenarios I want to talk about. First is a single implant bound by 2 adjacent teeth. We know that the papilla is bound by the proximal bone of the 2 adjacent teeth. In order to understand predictability, first I always do bone sounding on the adjacent teeth. We know the normal distance is around 4.5 millimeters from papilla tip to the underlying bone. After bone sounding, if that number is less than that, what that means is by doing tissue graft, mostly there's a chance to bring it up to 4.5 millimeters. However, inter-implant situation is a different beast. In my opinion, it's extremely unpredictable. Why? Because we know from the literature the normal papilla height between implants is approximately 3.5 millimeters. Therefore, it's already approximately 1 millimeter shorter. Now, once we ascertain if the papilla is less than 3.5, sometimes with tissue graft, we may be able to gain a little bit. However, if you have a bigger defect, despite using bone graft, tissue graft, sausage, block graft, titanium mesh, I don't care what method I use, at least under my hands, the predictability, the chance of getting a papilla is probably less than 0.1% chance. If we get one, I am very lucky. Why is that? Because remember, in the end of the day, it's not a matter about what technique, what instruments you use, because in the end of the day, it's the human biology that's going to trump over everything. Once again, EAO, thank you so much for this opportunity.
Thank you, Joseph, for explaining to us why, in fact, you should have voted false. And I say should have, Isabella, because we were looking at the votes coming in, and I quickly locked the vote when he came to his final conclusion, because there we see that almost 2/3 of the audience is voting through, a big majority. And then one I also love, almost 10% says, I don't know. There's people to educate here as well. But it seems that the common understanding of our active participants tonight is on the wrong side. Why is that?
Well, Gerrit, I think that Joe has very, very nicely and clearly explained that the key word is predictable and the key factor is the biology and the understanding of the biology. Now, saying that you can regrow predictably a papilla around adjacent implants or the implant adjacent to the teeth, which is more favorable, is a big statement. We have just come out of a beautiful battle session where they have been battling and discussing the treatment to try to achieve as much papilla as possible.
Yeah.
And one of the driving factors is the anatomical distance between the two implants, or the site, the symmetrical or unsymmetrical site. So the papilla is supported by the interdental or interimplant bone. So by definition, you have to have that bone. You can mask it, you can mimic it. If you're a skilled surgeon like Joe, you can achieve some improvement. But now saying that a papilla can predictably be grown, that's a big statement.
Yeah, that's how Joseph kicked off. The predictability is the key word here.
Yeah.
So how do you explain that so many people in our audience are on the wrong foot on this one? Is it a common, yesterday Eva talked a lot about Facebook science, Instagram science. Is this a common misunderstanding out
Well,
there?
it could be. What I think has to be said is that often the biological understanding, the deep biological understanding of the oral cavity, which frankly is very simple, because
It's
again,
simple.
well, we are dentists, okay? So I think that the biology and the anatomy of the oral cavity is relatively simple, and you have to acquire it
To this audience, yeah.
to perform and to do your job.
Exactly.
And often there is a rush to wanting to place implants and feel good about your surgeries, and perhaps you forget that the biology is not there, and no wonder why the results will then be in a way not satisfactory, especially on the long term. You may have a nice result in the first few weeks, months, but perhaps after 1, 2, 3, 4 years, then you end up with recessions and so on. So I do not explain why 60% said it's true. Perhaps it is wanting to, I don't know, overcome biology, or wanting to work fast and without respecting the basic rules.
Exactly. So is this another call for more education? We kicked off with more education on the human factors. Now we should also spend some time on really understanding the core biology?
Yes, well, certainly. But this is something, conversely, from the human factors that is very well described, explained by mentors, by professors, by university postgraduates. Yes, certainly, obviously, it's a clear message, but I think it's a banal message to refrain from educating. This is a message for the young ones, educating yourself through Facebook or images on Instagram, that's for sure. But I would assume that the population is not learning from Instagram.
Exactly, but there's a lot of things being shared.
Well,
Beautiful
the
cases
EAO is
on Instagram. Hashtag EAO Digital Days. In the last minute, Isabella, let's see if this is for your knowledge or not. Question from Ahmad Hassan. How far must be the bone from the papilla for this to form? Is there an ideal distance? Anything that you can just say from the top of your head?
Yes, the ideal distance, we have studies saying that the ideal distance is between 4.5 and 5 millimeters from the contact point to the basal bone, to be able to have this pink, beautiful triangle. And that's once again why Joe Can was very clear about the fact that it is unpredictable if these measurements are not respected. So perhaps the people who said true.
Yes, I see the light bulb going on in your head.
Now, perhaps the people who voted for true is because they assume that they are positioning implants in intact sites where adjacent you have the bundle bone of the tooth, and hence the biology is respected. that could be an explanation.
Exactly. So if all of you were saying, yes, yes, that's why I voted through and I disagree with everything being said, well, let us know. Enter in the chat. We're going to wrap up this session, but we can obviously have a lively written discussion as well. So we've hoped you learned a lot, and thanks to our experts around the world. More of these fast-paced answers in our Is It True sessions tomorrow at 8 p.m. So thank you, Isabella, for now. See you back in about 2 hours for the challenge of the night.